Okay, it is working. Okay, should be live.
Um, yeah. It says streaming. Hey Robert, on your Instagram, can you press live? Go live. You're on mute. You're on mute.
I'm live for sure.
Okay.
But the orientation looks
Yeah. I think to auto rotate. Is there a way to adjust the orientation, Chris? Because it's a vertical on app and it's cutting down to.
maybe
I'm not sure. I think that's an Instagram thing.
Okay.
um,
I'll see for once we start the session, and if it still it is, I think I'll switch off Instagram on both PNB School and Sona sites. Is that okay?
Yeah, I think that's all right. I'm going to go ahead and get started in about 30 seconds. All right. Hello, everybody. Welcome to the Sonosite webinar. We'll get started here in just a little bit. Going to wait for some attendees to arrive, and then we will get started. Right, looks like we have some attendees joining here. Go ahead and get started here in just a couple of minutes once we get some more people in. Welcome, everybody. Just waiting a little bit for some more attendees to come into the room, and then we'll get started. Welcome, everybody. Just waiting for a few more people to come in, and then we'll go ahead and get started with the webinar. Okay, wait just about another 30 seconds or so, just to make sure everybody gets in on time. Okay. All right. Looks like we have a good amount of people here, so I'll go ahead and get things started. My name is Chris Pennell. I'll be moderating today's webinar. I'd like to welcome everybody to Sonosite's Behind the Scan webinar titled ERAS, Utilizing Ultrasound-Guided TAP and Rectus Sheath Blocks. Before we begin, I have just a couple of things to cover. For one, all attendees are muted, and we'll be conducting a Q&A session at the end of the presentation. And we are currently broadcasting this webinar on multiple platforms. And in order to ask questions, you must be on the main Zoom webinar stream. If you're on the main Zoom stream, you can type your questions into the Q&A box in the toolbar located at the bottom or the side of your screen. And you can feel free to enter them throughout the presentation, and we'll get to them once the main presentation is over. This webinar will be recorded and archived for future reference on our webinars page. And here with us today, we have Robert Thal. Robert Thal is a certified anesthesiologist assistant. Robert has been part of the Ohio Anesthesiology Group Southwest Division at Southwest General Hospital for the past 24 years, where he is the chief anesthetist. He's also the clinical coordinator at Southwest for the Cleveland Case Western Reserve University CAA program. In 2016, Robert created PNB School, which focuses on expanding the use of ultrasound-guided regional anesthetic techniques. He's taught at numerous anesthesia training programs around the country and given talks to industry leaders around the United States. Robert, thanks so much for being here, and I'll go ahead and turn it on over to you.
Thank you, Chris. It's a pleasure being here. I always enjoy these webinars, especially with Sonosite. You do a great job putting everything together. Thanks for having me. And I want to go ahead and just welcome everybody tonight. Hopefully we all get something out of this. I certainly look forward to the question and answer session, and look forward to answering some really good questions. And feel free to ask questions about anything ERAS, anything TAP and Rectus, or any other kind of block you might have. With that said, please enjoy the presentation, and look forward to the end to speaking with you all.
Hey everybody, it sounds like you're not hearing audio right now. Is that correct? Let me see what I can do about that. Just one moment. Sorry about this, folks. Just one moment. All right. Okay, let me try this one more time. Sorry about that, everybody.
Thanks, Chris. Thanks for having me. Happy to be here. My name's Robert Dahl, as you said, from PNB School. I'm an anesthetist southwest of Cleveland, Ohio at Southwest General. And I'm excited to be here because I get to speak on some of the procedures that we use on a sometimes daily basis, definitely weekly. And I get to share what we do at Southwest and how we've tweaked our procedures and blocks and for abdominal surgery. So today we're going to speak on ERAS utilizing ultrasound-guided tap and rectus sheath blocks, and it should be a good one. So some of the basic points here are some of the summary benefits from ERAS, from abdominal surgery, some of the goals that we have. It should all be goal-oriented. So I think many of us know these goals by now, but definitely one of the biggest is shortened length of stay in the hospital, and that's a measurable outcome for sure. Decreased overall complication rates, decreased infection, DVT, et cetera. Decreased 90-day readmittance rates, which is important because of the global fees now. Decreased pain scores, which is important. Again, most of what we do is driven by Prescani scores, feedback from patients. So if they don't have pain, those scores usually go up. And of course, decreased nausea and vomiting. Overall, is the goal is increased patient satisfaction. So if you summarize all of that, patients get home faster, they have less complications, decreased pain and nausea and vomiting. Overall, patient satisfaction is going to be increased. So then it's the how. How do we accomplish these goals? And really the key is early ambulation. Again, no secret. It's been written about in numerous papers. But then it's how do we get these patients to ambulate a little bit earlier? Better pain control for sure. That's probably top two with nausea and vomiting. So decrease nausea and vomiting, increase your better your pain control one way or another, and then return of normal gut function is just as important. It goes hand in hand with nausea and vomiting as well. And so how do we do that? We usually think about limiting opiates in some way. We found out that opiates are very useful. We know that for a long time, but how we use them has changed over the years, and definitely in my practice, how I use them. I try to limit it and give just what I need to give to get patients through surgery comfortably into the postoperative period. And then, of course, with regional anesthesia, combine those two to decrease the opiates, and your gut function gets back to normal, and you have a decreased rate of nausea and vomiting. Other keys to early postoperative patient ambulation. The biggest one that I think gets left out, and I tell everyone at our hospital how important it is, at least every other week, is you need to establish patient expectations. So you need to establish, the ground rules for what their part in all of this is going to be. And there's a really good summary here in this image of how to get that done. So at every point of contact for the patient, you want to reinforce what the expectations are. If they're having a bowel resection, robotic, laparoscopic, or open or otherwise, you have to tell them what what their expectations are. So when they go to the surgeon's office, we want to tell them, hey, you're going to have surgery. We're going to tell them all about the surgery and post-operative care they're going to get. And once they hit that floor, we're going to tell them what their expectations are. We can define those any way we want. So it could be sitting at bedside within a couple hours. It could be walking within an hour, taking 10 steps, 20 steps, traveling 30 feet, whatever we decide. Then in pre-admission testing, they're going to hear the same thing. In pre-op, before the surgery, the nurses are going to tell them the same thing. The surgical team, of course, and anesthesia are going to tell them the exact same expectations. And by the time they get this surgery done and get to pack you and then up to the floor, they've already heard it 7 times. And you'd be amazed just by reinforcing that. What happens when they get to the floor is they follow those rules and the expectations are met. They're sitting at bedside, they're walking within hours, and everyone's on board. So to summarize, avoid postoperative nausea and vomiting. We want to include proper volume replacement. I had to mention that because we don't want to overload the patient with fluids, but we don't want to make them hypovolemic as well. So euvolemic usually, if it's a bowel case, a little bit less. So multiple antiemetics, pre-op, intra-op, and post-operatively, and then treat any other emesis post-operatively with rescue antiemetics now that we have. And again, decrease post-operative nausea and vomiting. How? Maybe limit opiates. We need to limit opiates in some way and just use an appropriate amount if we're going to use them and get that gut function back as fast as we can. So how do we do that? Adequate post-operative analgesia is one of the ways. And how do we do that? We use multimodal approach for analgesia on these cases. And we can define this however we want. There's not one way to write an ERAS protocol. And your surgeons are going to have input. Your nursing staff's going to have input. Everyone in the anesthesia group's going to have input at some point. So we use combinations of the drugs here, NSAIDs, ketamine, dexmedetomidine, magnesium, local by the surgeon on top of the blocks. Hemodynamic modulators, beta blockers have been shown to affect substance P, gabapentin, and propofol with an asterisk because I understand the slide says analgesia. And we've been taught propofol as an anesthetic, but there are ways to use propofol to blunt responses to stimuli, and we know it's very short acting. And so if we can get patients through periods that we know are going to be stimulating with propofol, it's a huge benefit because it goes away so quickly. And so that's probably information for a whole nother talk. So we'll try to stay on task here. And of course, how do we limit or avoid opiates? One of the best ways we control analgesia that we've seen over the last probably 20 years is ultrasound-guided regional anesthesia. So that's when I got involved in this, and that's been one of the best ways that we can control pain for abdominal surgeries. So we want to talk about TAP and rectus blocks, and I'm just going to speak on our approach, the Southwest General approach. We almost always, for abdominal surgery, perform bilateral, subcostal, ultrasound-guided TAP and rectus sheath blocks. That excludes open umbilical and inguinal hernia repairs because for those, we could just do rectus sheath or a one-sided TAP block. But whenever we're speaking on robotic or laparoscopic or even large extended exploratory laparotomies, usually we will use bilateral, subcostal, TAP, and rectus sheath blocks to help with perioperatively with pain. So, and I always get this question. So why TAP and rectus versus QL? Because there are some big QL believers and they use it during these surgeries as well. So why TAP and rectus versus QL is a good question. And for us, it came down to a few things. And number one was consistency. So TAP and rectus blocks are very reliable. We know they do not provide visceral pain relief, but they provide very consistent and reliable somatic relief. QL1s, anecdotally for me, I did maybe 50 QL1s before I decided that it wasn't the block for us because QL1s were hit or miss. I could put the medicine in the exact same spot every time, and I just did not get the consistent results that I needed to be able to tell patients and surgeons that they were going to have really good pain relief post-operatively. The other reason is that the TAP and rectus blocks are technically easier, in my opinion. QL1s are easy, but QL2s and 3s are technically difficult, meaning for all of our anesthesia providers, they weren't going to perform those at a high rate of success. So all of our anesthesia staff is comfortable performing TAP and rectus blocks, even on morbidly obese patients. They're just simpler. So it's all for our group. It's all hands on deck. All anesthesia providers perform blocks, and so whoever's available, if you're available to come and help, be a third person even, that's even better. So it's all hands on deck. We train everybody to perform the blocks that we normally need to do on a daily basis. So all hands on deck. In our protocol, I'm not going to get too specific, but multimodals begin in pre-op and continue perioperatively. You can decide what multimodals are best for you, your patients, and you know your surgeons the best. Tap and rectus blocks performed before incision. And that's important because you get ahead, you're going to blunt that response to incision, so you're going to decrease the amount of opiate you need. And these blocks aren't surgically analgesic. We know that. We just feel it's important to block these patients before incision. And that's an argument against surgeon performing, and I put in quote, tap blocks. I've seen them describe peritoneum injections with local, like a block, as a tap block, which isn't truly a tap block, but it works. It can work pretty well if they're good at it and very specific with their injection. But it's also after incision. So we're already going to have to treat the pain with opiates from incision, and then the blocks will come later at a later time. So we like to get out ahead of it, put the tap and rectus blocks in before incision. And again, they're not surgically analgesic. So a small amount of opiate given on induction goes a long way. And we try to time our opiate really well to minimize how much we need to give. Timing is everything, especially to our surgeons. So the next slide will show, the timing, the workflow of the tap and rectus blocks. When are you going to perform these blocks? Are you going to perform them in pre-op? Are we going to perform them in the OR? You need to have an efficiency in mind to get everything done and not delay surgical cases, especially at our hospital. That would never fly. So you want to have everything together, get your supplies together, assign anesthesia roles. So if it's an anesthetist and a physician, or if the physician needs to call someone in as well, extra, or two physicians, just assign who's doing what. One does airway, one does blocks. And the procedure begins, just after induction for us. So what we'll do is we'll induce the patient, and then we'll utilize the OR team to prep and drape for the block immediately after the patient's asleep. So I know in anesthesia we're taught, the airway first, but we can definitely work in parallel. They don't have to disturb us. They're not moving the patient dramatically. So we can prep and drape for the block just after we've gone to sleep. And usually we utilize our OR team for that. The PA or SA will do that, the resident, whoever's in the room at that time. And then we've already dedicated one person to perform the block. So they're pushing the ultrasound over while we're intubating, getting everything ready. And they'll do the block as we're taping the tube, getting other things done, getting the anesthetics set, the vent settings. And really at this time, you have to think, especially if you have somebody new at these, you want to limit the time you allocate to complete the blocks. It's not a race. You don't want to rush, but it shouldn't take you 20 minutes to do these blocks. These are pretty simple and straightforward. So if it takes longer than you deem acceptable, just abort it or give it to somebody else and see if they can't get it done faster. But there should be a time limit to these blocks so that you don't delay the surgeons. If you do 3 of these cases in a day and you add 10 minutes per case, that's probably a little bit too long. 5 minutes would be much better. But again, it's all hands on deck. Everybody's helping. Everybody's in on what we're doing. And actually, what we've seen is our staff take great pride in helping us. I mean, they started gloving the anesthesia provider on the way around the bed to do the blocks. They're prepping. They're asking to prep. They're all over it. So it's been fun to watch. The idea here is to work in parallel. 2 groups working at the same time, performing different tasks so that we cut down on time. It's just trying to be efficient and just using common sense to get the day done a little bit quicker. So the tap block, just a quick review here. I think this is a common block used. The target is the lower 6th thoracic nerves, T7 to T12 and L1. We're going to talk about that a little bit. I think the target there is a little more T9-ish for taps, and that's maybe why we're going to be talking about rectus sheath blocks as well, but we'll go over that. There's some great images on that in a little bit. The target for the local anesthetic, we want to inject the local superficial to the transverse abdominis muscle and deep to the fascia above the muscle. That's important. You need to go deep to the fascia, so you need to enter the fascia, pop through it, and stop above the muscle. Again, provides somatic analgesia to the abdominal wall. No visceral pain relief. And we'll kind of try to break this down the best I could do here with this image. So we have the external oblique. And as we peel layers away, hopefully you kind of get an idea. There's the internal oblique. And then one more down will be the transversus abdominis muscle. And you can see the little thoracic nerves run through this plane that's highlighted here. Deep to that is the peritoneum. We obviously want to avoid that. And we want to just try to get the local where these little nerves are innervating the abdominal wall. This image shows exactly where we should inject. If the needle is the yellow arrow, we're going to pop through that fascia layer above the transverse abdominis muscle and inject just above the muscle. And sometimes people are a little confused. They think maybe we're within the fascia, but if you pop through the fascia and inject, you actually compress the transverse abdominis muscle deep. Okay, it compresses against both layers of fascia above and below and the local. And so it kind of forms a line on top of it. And then the line above the local, and you'll see that in a video here, the line above the local will be the fascia still. So you'll see two lines, but you inject deep to the fascia. I want to mention it's important to consider probe placement while performing the block because this is a volume block, but if we're doing 4 blocks in all, the volume may not be as high as you would really like. So depending on your probe placement and where you perform this block, it might dictate a little bit what kind of coverage you get. So probe placement's very important. And I mean anterior, posterior, and cranial caudal. So again, I said before, we always perform these blocks just subcostal. And you'll see why in some images here. But when we combine it with the rectus sheath, we're going to try to get as much purchase as we can with all of these blocks. So we perform it subcostal at the anterior axillary line for optimal coverage for us. I never know where the surgeons are going to put the ports. Okay, I could stare at them every single case I do, and I can never figure out. There's always one that I would have never guessed. And so I want to get as much purchase on the abdominal wall as possible so that if I have one robotic port or a drain site that's not covered by my blocks, I don't feel horrible afterwards because really we haven't done any justice for the patient at that point. So just a reminder of some of the anatomical lines here: mid-axillary line, anterior axillary line, costal margin, T10 level. I know, pretty basic stuff, but our goal for the tap block is really this anterior axillary line for how we do these. And you'll see an image of how the local spreads at that level. Most people think the T10 level is where you put your probe for all taps when they first start this, okay? I've always argued that just stay subcostal and you'll get better coverage overall. You can follow the costal margin with your probe. You don't have to be transverse across the abdomen. Just use that costal margin as one of your landmarks. So here you can see why probe placement is so important. As we move the probe anterior and posterior, it kind of shifts the coverage of our abdominal block. Now we're going to have local spread in all planes, but you can help yourself out by placing that probe at the mid-axillary, anterior axillary line there. The blue circle is where our target is usually. You can get a little bit more anterior coverage by using the orange line, a little bit more anteriorly there. But remember, we're also doing rectus sheath blocks, so that's going to cover more midline as well. It's really comes down to the volume that you're using. You need higher volume to get better coverage. So this will show you kind of how we'll just track that costal margin with the probe and wind up at the anterior axillary line, and then bring our needle in medial to lateral in plane. Okay, these blocks are all done with the in plane approach, and right at the anterior axillary line, just that looks about right there. And then our needle will come from the medial side and will be in plane. And you can see how our volume kind of spreads there. We'll inject, and this isn't medical advice, any of this, but what we do is we inject about 20 mils there with our other blocks. So 20 mils on each side for the tap block and 10 mils each side for the rectus sheath. We get really good coverage. We cover most of the abdominal wall with that. So subcostal, anterior axillary line is the volume block, fascial plane block. This video will show proper local placement after the initial improper local placement. So you see the needle come in there from the medial side, and it's going to enter what I thought was the fascia above the tap plane. And it's not correct. I could see the fascia intact below, and now you could just see it pop through that fascial plane and inject again, and it pushes the muscle down a little bit. I could feel the pop better, and so we just readjusted a little bit. I love this video for that fact, because nothing's ever perfect. You just have to keep adjusting until you get what you like. And then once the local's injected, I always move into that space and then continue the injection. Make sure I'm in that plane, and you'll see the local spread nicely. Kind of, people talk about the unzippering effect, but definitely open up that space all along that plane. So the tab block coverage, again, this shows where that anterior axillary line, that injection at that level, and you can see we get T10. We're not going to get T7 with that tap block, and so this is why we add the rectus sheath block, again, just subcostal, and you can see the kind of coverage that we're after with the rectus sheath block as well. So with the tap block, filling up where we inject it, getting as much purchase as we can with that block, and then adding the rectus sheath block adds a whole nother level of coverage for the abdominal wall. Rectus sheath block, quick review here. Again, very simple block, targets the anterior cutaneous branches of the intercostal nerves, and literature says T7 to T12, pretty accurate. T7 with volume to T12 for sure. With 10 mils that we give, we get pretty good coverage. So local anesthetic is deposited deep to the rectus muscle, superficial to posterior rectus sheath. So just posterior to the muscle, just deep to the muscle, okay, and just anterior to the rectus sheath, just superficial to the rectus sheath. Provides, again, somatic analgesia. So no visceral coverage, again, a straightforward block. And here it's a little bit hard to peel some of these layers with the program I use here, but you'll get an idea. There's the anterior rectus sheath, the fascia there, and then of course the rectus muscle. Yeah, it's okay. And then the posterior rectus sheath. There'll be other images to show that as well. So, in fact, there's a labeled image of that. So here's the image right here. So the needle's coming from the medial side. We can see there's the rectus muscle, the belly. So medially, the linea alba would be medial off this screen between the recti, and you can always start your exam there and then just move lateral to either side. That's a good way of finding the rectus muscle, especially on obese patients. Important here is the transversalis fascia, which is that orangish yellow line, and then the peritoneum, which is the green line. Forms two lines beneath, deep to the rectus muscle. Many people often think when they're learning this that you inject between the two lines, and that's not the case. You're going to feel the transversalis fascia with your needle. It's going to be a blunt tip needle, hopefully, and you're going to inject at that point, and you're going to see another, an unzippering effect there. It's going to push the muscle anteriorly, and then the local will spread along that transversalis fascia, and you'll get really good coverage with a small volume here. So again, subcostal block, it's also a volume block. Anytime we talk about fascial planes, usually it's a volume type block, better coverage with higher volume. And you can start your exam midline and then move lateral. So you'll see linea alba, you'll see both recti, and just move lateral so that you center one of the rectus muscles in your ultrasound image. And then for us, I always teach medial to lateral in plane approach. I think there's some blood vessels you can get into there laterally. So to avoid that, a medial to lateral approach is a little bit better. Notice how the probe is angled to mirror the costal margin. It's not transverse across the belly, and that's done on purpose here. So you can just mirror the costal margin and use that as one of your landmarks. Video here. Again, rectus sheath block is pretty straightforward. The rectus muscle, the posterior rectus sheath, same image that was labeled. You'll see the needle approach medial to lateral, and there's that unzippering, really straightforward. You're going to feel that transversalis fascia with the needle. You can stop, you can inject a mil, open up the space, and then continue injection once you're sure where you are. So the rectus sheath block, again, immediately subcostal. The goal is to get a little more cephalid coverage than the tap block, I believe, provides. So T7 is pretty consistent, and it's going to be more anterior medial wall coverage. Again, combined with the tap block, you're going to get great coverage of the abdominal wall. Interestingly enough, cadaver dye studies, there's one just kind of done. When you inject the recti at that level, the local anesthetic will spread along that sheath, will spread caudally. So you'll get great coverage depending on the amount of volume that you inject. And they've done dye studies to prove that, and we see it in our incisional coverage every time we do these blocks. So even if a laparoscopic procedure is converted to open, we'll get really good coverage of that midline incision. So I'm very confident, anecdotally, that these blocks work really well for perioperative pain relief. So again, and this needle comes in from the lateral side only because I thought I would run out of room on the if it came from the medial side. But you can see a single injection bilaterally. This will spread along the sheath, and this is where we get great coverage from the rectus block, even for midline incisions. So to summarize this again, this is our tap block incision. We combine it with our rectus block because we don't feel it gets cephalid coverage enough. It doesn't get to the T7 level as consistently as we would like. Even an anterior injection wouldn't get there. So we add the rectus block bilaterally, and we get great coverage of the abdominal wall from both of these blocks. So we'll do tap and rectus blocks bilaterally. And, it usually takes us about, people laugh at this, but maybe 3 or 4 minutes on average to get these blocks in. So it's not a race, but it's a challenge. We like a challenge for sure. Add your multimodal analgesics. We know the tap and rectus blocks aren't surgically analgesic, but we know what to expect with them. We know they're consistent, and we can really apply our multimodal analgesics in a timely manner to help the patients be relatively pain-free perioperatively. Antiemetics as appropriate, pre-op, intra-op, post-op, and then rescue. So have them all lined up. Have some sort of protocol so that you can track it, your outcomes, and then you can tweak it as needed. Minimize overall opiate and maximize a small amount of opiate with optimally timed dose. So timing of opiates is really important. It can really decrease the amount of opiate you use if you time it well. So you can blunt the response to intubation with a little opiate. You can blunt the response to incision with a little opiate. And then everything else, the multimodals and the blocks should carry you through the rest of the procedure. And if it doesn't, you have the right to give more. But less is more, but the timing of the opiates are really important to us. I teach that to everyone I work with as much as I can. Be efficient with the blocks to gain surgeon buy-in. Be ready. Have everybody on board. Utilize the team. Usually the assistants are kind of standing by while someone's helping with anesthesia. So you can put them to work or ask them to work or talk to administration and see if you can't get something together. But we definitely, I love seeing it. They take part in it as a team. It's great for everyone in the program. They take pride in what we do. So it's not a race, but when we perform these blocks in about 3 or 4 minutes and everything goes as is planned, everyone takes pride in that. And so it's good for the team as well as the patient. The number one contributor to great success with these blocks, or even our total joints and those blocks, set patient expectations early, get them ambulating. And that takes the whole perioperative team all the way up to the floor nurses. They need to be on board about what we're trying to do. And you have to educate. You have to educate everyone, tell them what the goals are, define everyone's role, and work together. And then, get their feedback, make sure that they're involved in the system. So setting patient expectations early, very, very important. That's it. Thanks for having me. Jody, Sonosite. I love speaking on some of these procedures and ERAS protocols and the things we do at Southwest and sharing them with everyone. I know everyone does things a little bit different. I love to learn from everyone. So to be able to speak on something like this that we get to use daily or weekly is a lot of fun for me. So thank you again, and hopefully everyone gets some use out of this.
Sorry about that. Thank you so much, Robert, for that excellent presentation. We got quite a few questions that came in. So let's see. The first one is, any use of goal-directed volume replacement with flow track monitors?
Boy, that's a great question. And the quick and simple answer is no. And we don't have the equipment And it's not anything that anyone's pushed for or asked for, to my knowledge, either. It takes, as you all know, probably, it takes a lot of work to get a protocol and a system in place. And so for us, it's been baby steps, and we've gone 2 steps forward, 1 step back, but we keep going forward. So I mentioned surgeon buy-in there at the end, and it's important, and especially at our hospital being a private practice hospital. So these private practice general surgeons especially can really move, and we're giving them 2, if not sometimes 3 rooms and 3 teams, believe it or not. And so just to not slow him down sometimes is a lot of work. So no, unfortunately, I don't have much experience with that at all. His surgeries are pretty quick, and our other general surgeons are pretty quick. So as far as volume replacement, we keep it pretty simple.
All right. And next question is, what about low thoracic epidurals for laparotomies? Are those used at all?
Yeah, not at our hospital, not for years. We used to use thoracic epidurals for all kinds of surgeries, nephrectomies, other open, large laparotomies, and they're really the gold standard as far as I'm concerned, as far as analgesia goes. There's a whole nother risk profile. And also, most of the time, our goal is to get our patients walking really fast post-operatively. So we've kind of gone to this ultrasound-guided, peripheral nerve block technique and this ERAS protocol and manage patients that way. So over the years, that's kind of fallen by the wayside, but definitely within my career, we were utilizing thoracic epidurals and even low thoracic epidurals for laparotomies as well. And like I say, they worked great. I mean, if you want someone to have less pain, that's the way to go. They're excellent. So good question.
Nice. And a follow-up to that, are these all-day surgeries that you're working on?
Our hospital, I would say the longest surgery would be 6 to 7 hours. It would be like a very complicated colon resection with maybe some adhesions. So that's probably the longest surgeries we're performing. And we get probably 20 hours out of our tap and rectus blocks, I would say. So yeah, pretty long, but not all. I wouldn't call them all day surgeries.
Gotcha. All right. Next up, we have in laparotomies and abdominal surgery, what data compares UGRA tap and rectus block efficiency or efficacy versus Exparel or other catheters directly administered by surgeons to directly visible tissue planes?
I don't have the study right off the top of my head, but that's a very direct question. And I'm trying to think, there's probably data there, but I just can't quote it at this time.
Gotcha. And then after volume blocks, what volume of local do you advise surgeons who want to add at the end?
So it depends on the length of the surgery, obviously. And like I said in the presentation, we're doing 20. I'll dilute the local just for this reason. So I will use 0.375% ropivacaine. And so I will dilute the 0.5% a little bit, and I will use 20 for each tap, 20 mils, and I'll use 10 for each rectus block. And as long as the surgery, and most of these abdominal surgeries are longer, I'm comfortable with them using 20 mils of 0.25%. We usually don't get that question even asked. It's been so long to inject, and the patients do fine.
Excellent.
Good question.
Next question is, what are you using for your LA?
Yeah, so I just kind of answered that, but ropivacaine, 0.375% will dilute it a little bit just to give us a little more wiggle room at the end when the surgeons want to inject the ports, or even in the beginning if they have a little epinephrine in their local and they want to utilize that to stop some of the ports from bleeding. So we'll just dilute it a little bit. And I've had luck, and I think for other reasons I've diluted sometimes to 0.25%. And it seems to work close, if not as well as the 0.375. So it's semantics there, I think, as far as the how much analgesia you actually give. It's tough to tell sometimes.
Gotcha. This is a follow-up to the previous question about the all-day surgeries. He said, what I mean is, do the patients go home that same day?
So both. So some patients go home same day, and one of the interesting things we found, and probably one of the reasons why this presentation came up with Sonosite, is through COVID, the hospital administration were advising us to cancel any admissions, any surgeries that needed admissions that weren't emergent. This was just at our hospital. I'm sure some of you experienced that. And all of this worried us, the volume decreasing and what we were going to do with staffing. And one of the things we offered, that I offered immediately, was because I didn't know if all the surgeons understood that, they weren't sending all of their hysterectomies home in the same day. And I think with what we had done with our blocks and our ERAS protocols, I think it was time to kind of have that conversation with some of these physicians who just weren't comfortable for one reason or another, sending their hysterectomies home the same day. And that was a real positive that came out of this, is that they understood that they could do that. Excuse me. So a certain percentage, the hysterectomies go home the same day now. Even our GYN surgeons have requested we do these blocks for everybody, for everything, even if it's a tubal ligation, depending on where they're putting their ports. So some of the patients stay, some of the patients go home.
Excellent. Next question is, what percentage of peritoneal puncture do we advise patients for rectus sheath blocks?
I don't quote a number. I say very low risk to insert the needle into your abdomen and cause trauma. And to my knowledge, I still haven't heard of a poor outcome from that happening. And some of the other experts that I speak with around the country really haven't had any issues with it as well. So I'm not quoting a number there. I'm just going over generalized risk and that explaining that is a risk, and it's always a risk. So no number on that one.
Okay. Next one is, our surgeons can be in the abdomen within 5 to 15 minutes of induction. Since large volume locals are likely lower concentration, slower onset, how long do we need to ask surgeons to wait before incision for preemptive analgesic benefit?
I can only speak from my experience, and I've never waited and never had a problem, and these blocks work very, very consistently. So I don't know that there's been a study on this either. So just from my knowledge and from what I've done, at least over 1,000 of these, if not more. I don't keep track, but there's never been a problem with the surgeons being too fast and entering the abdomen and the local just kind of leaking out and having no effect. Yeah.
All right. What's your routine antiemetic therapy?
So as far as this protocol, for me, it's two types of surgeries. One is a bowel resection. One is anything abdominal that's not a bowel resection. So for our bowel resections, we're withholding Decadron. For everything else, I'm giving 4 milligrams of Decadron. I'm giving Zofran, and now we're using Droperidol again. And then I'll also a rescue antiemetic, Barhemis. We'll use that as well. But there's others for sure. That's pretty much it.
Okay. Next question is, Exparel or adding adjuncts to local?
Yeah, so I am off the adjuncts to local train. I don't add anything. I would use Exparel if I had it, and I don't have access to it. I haven't used it. I have limited experience with Exparel because we are unable to get it at our facility, and our pharmacy has been very clear about that. So we've tried multiple times, and we've tried for multiple reasons. And I know a lot of people are using it, and I would love to use it and try it and have my own opinions on it. I see the studies, but again, I would love to use it myself and see. I wish I could tell you more. Yeah, but I know a lot of people are using it for sure.
All right. I'm not sure if you answered this already. What is your local anesthetic cocktail preference?
Yeah, so for these tap and rectus blocks, it's still 0.375% ropivacaine. And then, double checking the volume. If you have a tiny patient, you definitely have to watch, but usually fall well within the max dose of ropivacaine.
Gotcha. Any use of liposomal bupivacaine for these blocks for longer duration of action?
Yeah, so I kind of answered that. It's just naming it a little bit different, but I wish I had that experience, and I wish I could talk about it more because I had the experience, and I know some out there are using it. And maybe in the future we'll come back and update this a little bit.
Gotcha. And for multimodal analgesia, do most people get magnesium and dexmedetomidine and ketamine routinely? If yes, what doses?
Did pretty good there, Chris.
Thanks.
Dexmedetomidine. Yeah, so I will use dexmedetomidine for our surgeons. They're pretty quick, even on the longer cases. And a lot of our patients are no opiate naive. They don't take a lot of opiates. So I will bolus my dexmedetomidine up to about 25 mics for the case. Non-bowel resections, I can use a pain dose of Decadron sometimes as well. Ketamine, I'll definitely use. Magnesium, I stay away from, only because of our relationship with our surgeons. I think they have asked us to stay away from it. I've offered it, and no one's really taken me up on that, and that's okay. So definitely ketamine, dexmedetomidine, and then if the patients are hyperdynamic still after insufflation, then I'll look to use some beta blocker, to kind of top things off. And then some well-placed opiate for sure. I'm not opposed to that. I can do many of these cases without opiate, but excuse me. Definitely 50 mics of fentanyl up front goes a long way. And that's kind of the message I was trying to get, that I'm not a big, huge opiate-free guy. I think a little bit of opiate goes a long way. So as long as we're using that up front and judicially, I think that makes sense.
All right. Next question is, how do we cover the higher T6 dermatomes of subcostal incisions?
Yeah, it's tough. You can add some local up towards the top of the incision. And I think that's probably the best way to do it with what we're trying to accomplish. So if they're really pushing the superior portion of that incision, I just think injecting local anesthetic right at the top might just cover that. It won't last as long, but it might get them walking a little bit quicker. And that's all we've really tried. So if they're really pushing that incision superior, then they're probably just going to have a little pain. You may just deal with that with a little opiate as well, to be honest.
Okay. How do these blocks compare with ESB?
So I have used ESP for thoracic. I haven't really used ESP for abdominal because we wrote this tap and rectus protocol. To compare the two, you would have to, this is a study-worthy subject, right? So the bottom line is, for me, is perform the blocks that, it's twofold, are most consistent for the patient so that you can tell these patients exactly what to expect when they wake up. And then number two, can you perform these routinely and quickly? So abdominal, ESPs, when are you going to perform those? They're going to be performed in pre-op, which might even be better. If you have to perform them in the OR, it's probably going to be a little cumbersome. And then, can everybody perform ESPs? Because at our place, it really didn't take off so far. So I never want to jump down that rabbit hole where only one or two people are doing ESPs, and maybe a surgeon views those as being better. And so it gets a little murky there. So yeah, no, I would love to read that data, but we do extremely well with our tap and rectus blocks. They're pretty straightforward, and everyone's in on it. So that's where we are now.
All right, fantastic.
Great
Well,
questions.
yeah, doesn't look like we have any more questions left. So Robert, thank you so much for being here and delivering just an amazing presentation and sticking around for the Q&A. Super helpful for everybody. Next time, check out our Behind the Scan webinars page on sonosite.com to see what's coming up next. And for everybody else, this recording will also be available there as well. So thank you again, Robert, for coming by, and thank you everybody else for coming.
Thanks for having me. Thank you.